Hello, and thank you for joining us today at this Race, Racism, and Health panel, the kickoff to the Science Museum of Minnesota's Science Celebration Days. These programs are part of a campaign to help museum visitors build their understanding of complex and layered racial and cultural issues. This year, Science is All of Us explores the disparities found in our communities, as well as in museums, with an emphasis on health. And so, I'm honored to welcome our wonderful panel of authorities in Minnesota healthcare to dig into some of the disparities in care and coverage for Minnesotans of Latin American heritage and discuss some solutions to bridging the gap. Today's facilitator is Dr. Carla Manzoni, board member at Hispanic Advocacy and Community Empowerment Through Research, also known as HACER Minnesota. Dr. Manzoni is a PhD in MA, also an equity strategist and community-based researcher and educator with 25 years of experience focusing on expanding the representation, success, influence, and power of marginalized communities. Welcome, Dr. Manzoni.
Thank you so much for that introduction. We really, really appreciate the invitation that the Science Museum of Minnesota did to us, this invitation to host and to have this space to talk about health of the Latinx community in Minnesota. Before I introduce the wonderful panelists that we have today, I would like to start a little bit with the context about the work that HACER Minnesota is doing. That's the organization that I serve as board member. HACER is a Latinx serving organization that has really helped do advocacy through research. And now that we are talking about health, COVID-19 has really put a spotlight on the inequities in healthcare that we have in Minnesota. These inequities that we have really a greater influence on health outcomes in general. And HACER has been like a real partner of the Minnesota Department of Health to really connect with those communities across Minnesota. HACER contributed with the Minnesota Department of Health hosting COVID-19 hotline, providing free and accessible COVID-19 vaccine, providing COVID testing clinics for the community across the state. We really try to help with food, health services, and employment regardless of immigration status. One thing that I wanted to really focus on as I continue to talk about HACER and the panel today is that without health insurance, accessing and affording good healthcare is very, very difficult. And the Latinx people face unique challenges related to immigration, work status, and communication. And we are going to be talking about all these issues today in the panel. So what I'm going to do next is introduce our panelists today. First, I'm going to introduce Rosa Tock. She's the executive director of the Minnesota Council on Latino Affairs. She leads a state agency that advises, informs, and educates state government and the legislator on policy and legislation to improve Latino Minnesotans' well-being and quality of life. Mateo Frumholtz is an epidemiologist at the Minnesota Department of Health and Refugee Health Program. During the COVID-19 response, he was a multilingual health investigator working with Hispanic Latinx community engagement teams to establish best practices for workplace health and safety. Mateo was one of the epidemiologists that described outbreaks in meatpacking plants early in the pandemic and worked on serology projects in Southwest Minnesota to better understand workplace safety standards and community transmission. Michelle Rivero is the director of the Office of Immigrant and Refugee Affairs with the City of Minneapolis. She advises the city on immigration issues and connects residents to nonprofit immigration legal help. Thank you to my panelists. So now we wanted to start with the questions. And the first question is for Rosa. In your role with the state, I'd like you to start off and share your perspective on some of the healthcare issues you're encountering and addressing on a statewide level.
Well, thank you so much. Buenos días a todos y a todas, a todes. It's a pleasure to be here and be part of this fabulous panel with colleagues that are really doing a great job in the community. So to get back to your question, Carla, what we do with the Minnesota Council on Latino Affairs is that we also visit with communities, and we try to get their experiences, their stories, and the recommendations directly from them. And in the past 6 years, we've been conducting listening sessions across Minnesota, talking directly with our community members. And what they have expressed during these conversations with them when it comes to healthcare and well-being are the issues that you mentioned, those barriers that have to do with lack of or limitations in healthcare insurance. That's like number one. That's the number one issue for them. But also the high costs of healthcare services, language barriers, and quality interpretation, immigration status, discrimination, and also transportation concerns. So they are very similar to what HACER has also found in the research. And two of the main priorities that we've heard from our community members are access to health insurance. About 25% of Latino Minnesotans lack health insurance in the state of Minnesota. And this is the highest percentage for all ethnic and racial groups in the state. The good news is that right now there is a bill at the state legislature that is trying to address that, particularly for low-income families and undocumented immigrants, is expanding Minnesota Care so that they can also enroll in this public option. So that's the good news. The other thing that they have mentioned to us is to have more and better trained medical interpreters. That's also a huge issue and problem, particularly in rural Minnesota, where there is a need for more medical interpreters. But I would have to say that the underlying factors that are behind these barriers that we've been talking about have to do with inequities in accessing health services and programs. That's one of the issues that our communities, and particularly communities of color, disadvantaged communities, and immigrant communities face. And there's also other factors, and those have to do with the social determinants of health. So it's not only lacking the access to healthcare or the absence of sickness or illnesses, but what are the other social, political, environmental factors that are also influencing those disparities or those health outcomes in our communities? And those, as you know, have to do with maybe insufficient access to good paying jobs, adequate transit, as we were mentioning before, safe and affordable housing, healthy food options, quality education. All of those are, as you know, are necessary conditions for conditions and opportunities for everybody to thrive. And this is where we are seeing most of the disparities. So we need to address them all together so that everybody enjoys a thriving life and can fully and equally have opportunities to thrive, no? And I'm going to mention one for you to consider, for instance, particularly in the immigrant communities and undocumented immigrant communities, and that's driver's license. Just that one is one social determinant of health that when you see them all combined, is so important for the health and well-being of our communities. For instance, with a driver's license, having that privilege reinstated, that means that people are going to be, they're going to have a peace of mind to start with. They're going to be safer, and the communities are going to be safer as well, just by passing the exam and having that document reinstated. And that also means maybe getting a job, because now they can apply for a job and they can drive to those locations where there are job opportunities. with that piece of document, which is also a piece of identity that for them is telling them, I belong here, which is another social determinant of health, belonging, pertenecer a una comunidad is so important for us. That will also allow them to bring kids, let's say, to after-school programs, to the parks, and a series of other conditions that are also part of having health and well-being. And another factor besides these social determinants that I'm talking about is structural racism. That's something that we also need to name and learn to talk about. According to the new commissioner of the Department of Health, Dr. Brooke Cunningham, she states that racism is one fundamental cause of diseases that could be preventable. So those are kinds of the conversations that we need to have more. And as Carla was mentioning, the pandemic made more visible those disparities and exacerbated them in our communities, particularly essential workers, who many of them already suffer of unequal access to healthcare and health insurance, chronic diseases such as heart disease, diabetes, mental health issues, etc. So how do we address them? As a state council, we bring those stories and those recommendations to the attention of the state legislature and the policymakers, but we also insist in something. Yes, there are challenges, yes, there are barriers, but we also insist in a new narrative for our communities, and that is that we are not a problem. We need to be valued and considered assets. We contribute to the state of Minnesota, everyone. And with that framework, we try to change the minds of those who are making decisions on our behalf, just to be considered equals among all the rest of Minnesotanos. So by doing that, we build awareness, and we support other advocates in the community. We are allies to advocates who are doing that kind of work at the legislature, and we also try to bring our own bills to make those changes. So I have to say that in the end, this is not only when we're talking about access to healthcare and the well-being of our communities, it's not only a human rights imperative, because actually I would say that healthcare should be a human right. It's a human right, actually, it is a human right. But when we think about how the state is changing in terms of demographics, we know that we are aging as a society in Minnesota, so it is also an economic necessity for the state of Minnesota. So those are my comments.
Mateo, now it's a question for you. Your work has focused on COVID response statewide. Can you talk a little bit more about what you observed working with communities in Southwest Minnesota and elsewhere to overcome vaccine hesitancy, and share any broader learning from these experiences?
Yeah, thank you. Thank you so much, Carla, and thank you so much for having me. Rosa, you really did a wonderful job of setting the stage for our conversation. So thank you so much for that. So in my role at the Department of Health, what we really noticed early on during the COVID pandemic, was specific outbreaks around meatpacking facilities. And one of the first ones was in the southwest corner of Minnesota called Nobles County. The biggest city there is Worthington, and a large proportion of folks in that county work in meatpacking facilities. As essential workers, they remained operational throughout the pandemic. When people went into lockdown, they had to keep working. I was one of the only epidemiologists at the state who spoke Spanish, and I and a very small team of other people had to interview every single person that got infected. And we were hearing the individual stories of everything that Rosa just laid out is representative of communities around the whole state, right? Individuals not necessarily having really good job protections, and being afraid of not going to work for being reprimanded for missing a few days of work, not getting paid sick leave like many other folks in the state of Minnesota do receive. A lot of them don't receive paid sick leave. Um, Being in a rural area, having very, very limited access to healthcare facilities to begin with, not having employer-based health insurance or any form of other access to health insurance, So it's a culture of not seeking healthcare when we need it because it's so inaccessible to begin with. And how does that transcend to vaccine hesitancy later on, as well as a lot of people kind of staying at home when they're sick instead of going to emergency care or urgent care. And I think a lot of that has to do with our healthcare system, to begin with more broadly. In the United States, we're the only high income country in the whole world who doesn't have universal healthcare or any other form of single payer system. Um, the number one reason people go into debt, speaking about financial hardships and finances being one of the key ingredients to the social determinants of health, having security and stability both in your finances as well as other areas. The number one reason people go into debt in this country is from medical debt. Over 100 million people are in medical debt today. And when we think of the Latina community, 22% of the Latinos in this whole country have medical debt. So, having universal healthcare, having that guaranteed access to a comprehensive health system is such an important factor when we're talking about health disparities, right? We often think of health insurance as a binary. We either have it or we don't. And if you don't have it, then you're in trouble. And if you do have it, then you're perfectly secure. And the reality is that there's this huge gray zone between having and not having health insurance, right? A lot of people who have medical debt have health insurance as well. It's just that our health insurance system is so complicated and so complex, and it's so hard to navigate that folks, newcomers coming to Minnesota and in the United States might not have that level of understanding as to how to best advocate for themselves in our very complicated health system. And I think we'll be talking about this later, but I think the question that I have is, do we really want to have a health system where we're forcing and requiring individuals to have to advocate for themselves? Or would we rather set up a healthcare system that's accessible to all, that provides high level quality of care to everyone as well? So, I think some of the lessons that we learned in the COVID pandemic was obviously the importance of having access to healthcare and health services, not only to treat those urgent situations, but also to start to create a culture where people feel like they can go to health systems and health services whenever they need them. And I think that the other really important thing we learned, especially from communities like in Nobles County, was the importance of bringing them into the conversation, making sure that they are represented in their workplaces, either through unions or community groups that are advocating for change in that local area. And also recognizing that, we hear a lot of the news at the national level and the state level, but there's a lot of really, really good concrete policy changes that can happen at the local level, in which these communities that are so strongly, tightly held together can get organized and advocate for and change for themselves.
Perfect. Wonderful. So last but not least, we are going to ask Michelle to share with us a little bit about her work with the city. Michelle, you work with the city of Minneapolis specifically on immigration issues. Can you talk about how immigration status and all these related factors affect healthcare and access in the area you serve?
Thank you. I'd be happy to. So I am just thrilled to be part of this panel. I knew this would be a learning experience for me as well. And I think this conversation is just so timely and so important. So thank you. The city of Minneapolis is home to over 63,000 people who were born outside of the United States. So it composes 1/6 of the population of the city. And the Office of Immigrant and Refugee Affairs was started in 2018, in a time where immigrant and refugee residents really felt the threat of federal policies that impacted people's ability to remain in the United States and also people's ability to access healthcare. I don't know if people in the audience are familiar with or have heard the term public charge, but the public charge rule, which has been changed to a version that is definitely more accommodating for immigrant and refugee residents during the previous presidential administration, really had an impact on people's feelings around ability to access healthcare and deterred many individuals from obtaining healthcare, and governmental agencies, including and offices, including the Office of Immigrant and Refugee Affairs, really had to consistently work to ensure that people knew that there are still healthcare options available that did not jeopardize a person's immigration status. So, with regard to immigration and immigration status as a social determinant of health, that is something that is very important and a focal area of the Office of Immigrant and Refugee Affairs from the standpoint of ensuring that people have access to immigration status, ensuring that people are connected to legal service providers so that they are able to acquire immigration status, which does open up healthcare options for people who are residing in our community. One of the things that we were involved in recently last year was a symposium on the healthcare impacts of irregular migration, also recognizing that the path that people take to come to the United States sometimes contributes to healthcare issues that they have once they arrive. This symposium was co-hosted by the University of Minnesota Law School and University of Minnesota Medical School. And it was called La Triste Frontera, The Sad Border and the American Dream, and really paints a comprehensive picture of challenges that are faced by immigrant and refugee residents, people who may have limited access to healthcare options, whether perceived or real. And I think the point that Mateo made was very well taken, that it's not like you have health insurance or you don't have health insurance. Sometimes, depending upon your immigration status, you may have the ability to access health insurance, but only for a brief period of time. And that's actually one of the things that I see quite often, where people are connecting with me because they have had health insurance, they've had access to healthcare, but they've lost it because of their immigration status. And so working to ensure that people have immigration status so that they have consistent access to healthcare insurance options is a focal area of the work that I do. And also working to ensure that people are aware of the many service providers, the many organizations, the many navigators that demystify the process of obtaining healthcare in the first place is also an objective of this office. Thank you.
Thank you. Thank you so much. There is so much to unpack here, and so much learning. And I think that in order to understand a little bit better, I would like you to share with us one project that you've worked on to bridge these gaps in healthcare that you have already identified. So if we can start with one project, and now we're going to start with Michelle. One project.
Super. So thank you. One project that we're really excited about, and this is actually a partnership between the city of Minneapolis and the city of St. Paul, is a 1-year citizenship campaign where we host events in locations that are safe spaces, trusted spaces in Minneapolis and St. Paul, alternating month to month. To help people learn about how to obtain United States citizenship. And we partner actually with the Minnesota Department of Health, have partnered with HACER to offer vaccinations at these events, recognizing that offering information in a holistic way about a variety of different topics is an excellent way to ensure that people understand the process of applying for citizenship, have access to healthcare providers. Literacy Minnesota also participates in these events. And there's even information about loan programs so that people can obtain assistance in paying the filing fees for citizenship. And we really feel like this is an excellent way to be in community, to have a regular space, a regular point of contact for people to learn about citizenship so that they can apply for themselves, can ultimately petition for their family members, and really be connected to the rich resources that exist in our cities.
Wonderful. Thank you so much. Now, Mateo, I'm going to ask you if you could please share one project that you work on in order to bridge these gaps.
Yeah, thank you so much, Carla. I think one project that our agency is really trying to work on and implement is to change how we do research with communities. And I'll give a specific example as to how this actually goes into practice. but it comes from this theory of us trying to essentially decolonize public health research practices, right? Traditionally, how we think of research practices, especially in the context of working with communities that are being disproportionately impacted, is, we go in with a research proposal, we extract all the knowledge we can from them, and then we publish it behind a paywall, public health journal report, right? That has a very, very colonial root mentality of, them serving the needs of our research and then hiding all the research and all the lessons learned that we took from their bodies, right? So the way that we've tried to transition this kind of practice is through more like community-based participatory research. So what we really wanted to do in Nobles County after COVID had impacted a lot that community was try to at least understand and ascertain the true magnitude of the impact that COVID left. So the first thing that we did was reach out to a lot of community organizations that were in that area. So for Nobles in this instance, it was Unidos Minnesota and also Voices for Racial Justice. They were some very great organizations that are working to engage the local communities as well as the meatpacking plants and the unions there. And we really wanted to sit down with them, meet with them, tell them kind of our proposal, what they, if they wanted to partner with us, what they wanted to get out of this partnership. So from day one, we really decided that, we had to essentially abandon all the preconceived notions of what we wanted to get out of this study and embark on this mutual shared power partnership to better understand the broader needs that this community had. So, through many, many, many months, we kind of started building this project. A big question that we wanted answered was, what is the true burden of infection, COVID infection in this community? And then not having necessarily the opportunity, the access to be able to survey a large sample of their community members, took this opportunity to do just that. So, we came up with a very comprehensive survey asking a little bit about COVID infection as well as, history of working, family, other things like that, demographics. But then we also had the opportunity to ask about, there'd been a question in that local community for a while as to if they wanted a community resource center, right? If they wanted kind of better engagement with these organizations in certain areas, how they could get connected and contacted with kind of local officials. So it was a great opportunity to join in partnership, to get all the questions answered that all the stakeholders wanted. And then again, the final kind of component of this theory is instead of kind of hiding this data behind a paywall journal, we went back to the community and did community presentations, sharing the results of the surveys with them, sharing the results of the serology study. And serology is a way of knowing if someone had been previously infected with COVID or not, which is something that they all really wanted to know, right? Because they had all heard from families, from friends that they all got infected, but understanding the true magnitude and kind of which workplaces were more likely to lead to you being infected was a really, really important conclusion for this project. So, essentially it's us kind of taking the lessons that we learned during COVID and trying to put them into our public health practice moving forward.
Wonderful. Thank you so much, Mateo. And now, Rosa, can you please share with us one project that was really exciting to really engage in to bridge these gaps?
Yeah, thank you so much. That was amazing, Mateo. Wow. I think that's what we try to emulate as well when we do our community listening sessions in Greater Minnesota with a more rudimentary kind of participatory research methodology, but that partnership and identifying the leaders in the community, what we call the community ambassadors, and they are the ones who have the trust in the community. Because when we go as state agencies there, I mean, the community doesn't necessarily trust government, as you know, but once you have those partnerships in the community and that we are there to listen and to learn and not to tell them what to do, I think that's where we have the most, the better outcomes for whatever purpose we are doing that kind of work in the community. But so we have many projects. The thing with us is that we are not, we don't provide services. We don't provide direct services. We are a state agency and we work at the macro level, at the state level in policy and legislation. And we don't develop programs and we don't have fundings to grant funding to organizations and nonprofits such as HACER and others. But what we try to do is to deliver other kinds of services, and mostly how we can influence and how we can change narratives, as I was explaining before, in different areas. And the one project that we've been working on in the last years with the Department of Health is changing the narratives around what it means to be healthy and what it means to have well-being in the community. So, and also shifting the belief that health is an individual choice, whereas we know that it's a public matter. And the pandemic actually gave us that confirmation that what the Department of, what public health is about. So it's not an individual choice, it's about the public and the community. So creating new narratives and influencing them from the Latinx perspective. So again, it's not only this absence of illness, of accessing direct care or preventive interventions, but how do we see other law? How can we change laws? How can we change rules? How can we change policies and regulations that will get people into what, as I was explaining before, a more holistic way of being their well-being. And so, for instance, policies such as we were talking a little bit about before, changing policies such as paid parental leave, the minimum wage, safe wage, pollution control, access to parks, to water quality. So putting into the changing the narratives and from our perspectives and cultural ways of being in community and being healthy in community. So you can add those particular things that are important for our communities. For instance, the family, how the importance of family, the importance of some rituals in the family, celebrations, dances, artistic expressions, etc. The spirituality that comes also as part of many of our diverse cultural expressions, etc. So it's really bringing new perspectives and new narratives as to how we can be healthy and how they can be measured as well as getting into better healthy lives and closing disparity gaps. All of that is important in the health of our communities, besides just the traditional paradigms of economic growth, and I don't know, it's more about, again, as I was explaining, something that is more related to our own experiences and creating this well-being.
Thank you. Thank you so much. Yeah, like taking the whole person and taking the community as a whole too, right? Wonderful. So I would like now you to give us a little bit of advice. Maybe share with us an insight. Maybe you can share with us, with the guest, how can we really advocate for ourselves in healthcare? And we're going to start with Mateo now.
Yeah, thank you, Carla. I think we definitely live in a very individualistic culture here, as well as in a very individualistic economy. And I think it's a very important question that has important implications based on the way we think about our responses, I think. So when we think about advocacy and health, a really big topic comes to mind that we have to address. And it's that health is political, right? It is, it always has been, it always will be. And it's important not to conflate politics with partisanship, right? Those are two separate things. So when we say health is political, and especially in the context of learning how to advocate for yourself, and also in the context of being in the culture and economy that really values individualism so much. My best advice is to rid ourselves of that mentality and start thinking about how we can get organized, how we can start collaborating with community groups, with our families, with our unions, with other stakeholders in the community. How can we collaborate so that we can learn from each other, right? So we can stop kind of operating in these silos. We all have our own lived experiences. Everyone has those lived experiences. And it's important to share those. It's important to collaborate, to meet other people, to get organized, because it's through that collective action that we will be able to improve the systems that are meant to be serving us. For example, a healthcare system, right? Polls show that the large majority of people want a better healthcare system. And the way to get there is through that political action of getting organized and getting involved. So that would be my advice. If you have a union, join it. If you don't, start one. If you don't want to, join your community group. I'm sure they offer, political education, political sessions. Here's what's going up on the legislature. Get connected to HACER, get connected to your city of Minneapolis, get connected to the MCLA and other offices at the state level serving, diverse communities. There's a lot of resources, a lot of groups working on phenomenal issues. And I think the goal is to try to get connected to them and help out as much as we can through this collaborative action.
Wonderful. Thank you so much. An advice or insight, Michelle, that you can share with us. How can we better advocate for ourselves in healthcare?
I'm a big believer in power statements, little mantras. Repeat them over and over. I'm driving to work, have my thought. And this power statement resonates with me. My family and I have a right to access safe and affordable healthcare in a language I can understand. My family and I have a right to access safe and affordable healthcare in a language I can understand. I strongly believe that individual empowerment and recognition that people have this right. They have the right to access healthcare. They have the right to understand their healthcare provider is incredibly powerful and is a first step. I also think it's valuable for community members to know, as Mateo is alluding to, there are so many entry points. There are the healthcare providers. There are the navigators. There are also other governmental offices at the municipal and the county and the state level that can help people access healthcare. The Office of Immigrant and Refugee Affairs is one point of contact. St. Paul also has an immigrant and refugee program. Hennepin County is another example, Office of Multicultural Services. So encourage people to reach out to us if there are questions, in addition to healthcare providers and navigators and other resources, because we're here for you.
Right. Thank you. And Rosa, can you please share with us a piece of advice? How can we better advocate for ourselves to have better health?
Yeah. Well, thank you, Michelle and Mateo. That was very inspirational and powerful. And I agree with both of them. I don't think that I have anything else to add, except that one thing that we all have, regardless of immigration status, regardless of whether we were born here or not, is that we all have agency, right? We can all, our voice matters. Not only our individual voice, but our community and collective voice matters a lot. Again, that's where our power comes with working as a collective for something that we care so much about, which is public health, and access to healthcare. So, and as a state agency, we have the responsibility to help you navigate the legislative process, to help you connect with your representatives. So again, no matter whether you came to Minnesota yesterday or 20 years ago, or you've been here forever, we have the responsibility to help you navigate a little bit that complicated system and connect you with your representatives. We all pay taxes here, we all contribute here, and we all have a representative. And it doesn't matter if you are a US citizen or not. They all represent us. So connect with us. We can guide you and tell you who represents you. We can connect you also with your respective representative or senator. And we are bilingual, so we can do support and help those who don't speak English connect directly with their representatives, because what most impacts the decisions that these policymakers and lawmakers are doing are our stories, our authentic stories, and those that come directly from their constituents. So that's why I'm saying that our voice matters, and in any way that any of us can support that, amplify your voice, we'll be more than happy to do that. Thank you.